invite Professor Ajit Avasthi sir to kindly deliver the oration.
Well, first of all, a very good afternoon to all those who are here. I feel so encouraged and I'm so delighted to see my seniors, my contemporaries, my very dear associates of PGI, and their presence really encourages me. At the same time, I'm so pleased to see them here. It's highly. I had not expected that such a galaxy of the audience I would have to address today. Well, friends, I pay very humble tribute to my great teacher, a revered mentor, and a very inspirational guide, Professor Narendranath Vig. Professor Vig has been very kind and held me in great affection, and I think it is indeed a great honor bestowed on me by the Institute, and thank you, Professor Viveklal, to deliver this particular oration in the name of Professor NNW. And I'm also very thankful to the Department of Psychiatry, especially Professor Basu, for recommending my name. And I really feel it's not a giant talking about giant, but a student talking about his teacher. That's all I can say. Well, friends, Professor Vig always held me in great affection, and it has been my pleasure actually to deliver an earlier oration named after him and instituted by the Indian Psychiatric Society North Zonal Branch. That is where I spoke about Professor Vig as the man who changed the face of psychiatry in India. That was in the year 2021. I don't know how many of you have noticed this particular watch which I support on my wrist. Actually, this is the same watch which I am wearing today, and it is a loving gift to me from my beloved teacher. Well, the topic which I have chosen today for this prestigious oration is the enigma of functional somatic symptoms in the practice of medicine. Well, my friends, it's all of us have to go through this periods of transitions and realities. You can see between my name and the topic, there is a huge gap. Actually, earlier, it was the emblem of PGI which used to occupy this space. I can't use it now, so it remains an empty space. Okay. Now, those of you who have been familiar with the works of Professor Vig would appreciate that functional somatic symptoms have been very close to his heart. He is the one who, first of all, looked into the bodily symptoms presenting post-sterilization in both genders. And he is also the one who has been looking at the bodily symptoms which would present in the context of a culturally held belief, which is called, the Dhat syndrome. In fact, the term Dhat syndrome has been coined by none other than Professor Vig himself. Well, friends, functional somatic symptoms are ubiquitous in clinical practice. Irrespective of the specialty, every clinician ends up seeing more functional somatic symptoms than any other ailment, almost in all specialties in any institute or in any college or in any clinic. They would see more number of functional somatic symptoms. They may ignore, may not take those into account in their own clinical practice, but those are there. These are ubiquitous. Not only that, it's highly enigmatic, highly mysterious for the clinician. They don't know what to make sense of it. They don't understand the head and tail of it. Whereas the patients are equally confounded and they are highly distressed. Now, if we look at the lexicon of psychiatry, there are two very similar terms which are used, and I think I must clarify that in the very beginning. One is the somatic symptoms, and other is the functional somatic symptoms, and you will like to ask me, what is the difference between the two? Well, the somatic symptoms are commonly used term in relation to various psychiatric disorders, such as depression or anxiety disorder. Whereas functional somatic symptoms, these are vague, non-specific bodily symptoms which remain medically unexplained. So these are not to be seen only in the context of the certain psychiatric disorders, but are seen everywhere. As per nosology, when we look at the depressive disorders, the term somatic symptoms in the context of depressive disorder essentially means the loss of interest or pleasure in activities that are normally enjoyable, lack of emotional reactivity to again the pleasurable surroundings, waking up in the morning at least 2 hours before the usual time, depression getting worse in the early morning, objective evidence of a definite psychomotor retardation or agitation, and marked loss of appetite, libido, and even significant weight loss. Now, this is the syndrome of somatic depression, which is seen in the major depressive disorder. As far as the functional somatic symptoms are concerned, this refers to a broad spectrum of symptom patterns wherein the patient presents with persistent, unspecific symptoms, quite burdensome, highly distressing, but yet cannot be classified as any medical disease. 2, these may be present, these symptom clusters may be present over an extended period and do present in certain specialties and get fancy names like fibromyalgia syndrome or irritable bowel syndrome. But these are mostly associated with significant limitation of functioning of the individual. In psychiatry, particularly, the functional somatic symptoms are sine qua non of the somatic stress disorders like the somatoform disorders, the somatization disorder, and lastly, they are often accompanied by not only the impairment of functioning and distress, but also certain psychobehavioral symptoms like exaggerated complaints, attention seeking, or marked severity of distress and disability. So there is a psychobehavioral symptom which goes with them in their presentation. There are many synonyms of the functional somatic symptoms. Chronic painful physical conditions, idiopathic physical symptoms, medically unexplained symptoms, which to my mind is a rather pejorative term to be conveyed to the patient. You tell this is a medically unexplained symptom. The patient will say, what the hell I'm here for? Then painful physical symptoms, psychosomatic symptoms, and then very specialty specific names like fibromyalgia in rheumatology, irritable bowel syndrome in gastroenterology, chronic fatigue syndrome, generally seen in the post-viral conditions in the internal medicine practice, and then non-cardiac chest pain as it is seen in the cardiology. So almost everywhere you find them. Now, in psychiatry, as I told you, they are known as somatoform disorders, part and parcel of somatoform disorder, somatization disorder. In gastroenterology, I have listed here the common symptoms which are there and are given these names, including non-ulcer dyspepsia. In cardiology, there can be palpitations, fainting attacks, chest pain, and you call it non-cardiac chest pain. In neurology, there can be a host of manifestations, and you call it non-epileptic attack disorder, conversion disorder. In rheumatology, again, you have very non-specific presentation of bodily symptoms, often known by the name of fibromyalgia. In infectious diseases, you have very fancy names like myalgic encephalomyelitis, or for that matter, the chronic post-viral fatigue syndrome, long COVID is well known to us, and what is it actually presenting with? Long COVID. It is presenting with functional somatic symptoms. Now, the dentistry in ear and nose and throat department, in allergy clinics, multiple chemical sensitivity, respiratory medicine as hyperventilation syndromes, in gynecology as chronic pelvic pain, when they have dysmenorrhea, painful urination, pain during sex, pelvic pain, and so on and so forth. And in military medicine, again, a myriad of presentations, often known by the war in which it is seen, and the last one was the Gulf War syndrome, and we may have a Ukraine-Russian war syndrome, or whatever you want to call it, henceforth. Well, if these are so non-specific, if they cannot be an indicator of a medical disease, then why we have to really think about them? Because, as I told you, they are very common. And how much common they are in community samples? Well, look at it. 10% of the community sample does present with functional somatic symptoms. And that's a huge number. And you can see that there can be almost the multiple aches and pains, GI symptoms, fatigue, vertigo, dizziness, and name anything that is seen in the community samples. And overall, as I told you, it is about 10% of sample. In a US primary care 3-year incidence study of 10 most common presenting symptoms, it was seen that, well, these symptoms are listed here, but the organic cause could only be suspected in a very small proportion of the patients who presented with each of these symptoms. The rest of, in the cases, you had no clue as to what is happening. Now, if you look at the clinical samples, the figures are startling, to say the least. Half to nearly 2/3 of the patients do present with medically unexplained symptoms, as it is so-called medically unexplained symptoms. In rest of the clinics, it is also not too far behind. Well, what is the association? Because generally they are seen by psychiatrists, so everybody thinks this is a psychiatrist's pie, so let them handle it, and taste it. So actually what has been seen is that the functional somatic symptoms, greater the number in an individual, greater the possibility of having a psychiatric disorder. And the cutoff is nearly about 10 symptoms per patient. If there are 10 or more than 10 symptoms, definitively the patient requires to be seen in a psychiatric setup and being treated like that. But that is the kind of the evidence they have. We also did a study, and I'm very glad to see my senior and even the current associate, Professor Subhash Verma. And we did this study with him with internal medicine. And we used the PRIME and the mental health questionnaire, which is a screening instrument. And we wanted to diagnose the common mental disorders. And during our study, we found that in about 500 subject sample, most common symptoms leading to consultation with physician are listed here, and you can all see those. But that's not, that I have made the point time and again. The more interesting finding is later now. 30% of the physicians opined that the subjects had psychological disorder. But when it came to referrals, the actual need for psychiatric referral was seen by only 2% of the physicians. Now you can see the gap. 1/3 feel the need, 1/3 feel that it's a psychological problem, only 2% feel the need for a psychiatric referral. So the rest go where? Or languish where, if I can use that hard term. When we looked with the PRIME and the questionnaire, what we found was equally startling. Panic disorder in about, I think any anxiety disorder in about 1/3 of subjects could be diagnosed. A quarter of the subjects did present with somatoform disorder. The mood disorders were seen in about 1/10 of the subjects. And overall, at least one psychiatric diagnosis was achieved by nearly half of the subjects. Now you can imagine that how much is the gap in terms of the presentation and the actual intervention. Another study that we planned, and actually the first study was rather in 2008, this is in 2010, and we used the Bradford somatic inventory, and we found a large number of functional somatic symptoms presenting irrespective of the gender. But the more interesting part was that the most commonly reported the functional somatic symptoms in the context of depressive disorder. Now we are seeing it not in a medical clinic, in an internal medicine clinic, but we are seeing it in our own psychiatric clinic in patients diagnosed with depression. The first two, obviously anybody can argue, may be the result of or the consequence of the depressive disorder or a mood symptom. But what about feeling of constriction of head, aches and pains all over the body, aches and pain, the mouth and throat getting dry, bitter taste in mouth, whole body feeling heavy, feeling of heat inside body, pressure or tightness and chest and heart. Now these are not the symptoms of depression. These are functional somatic symptoms presenting in. These are neither the somatic symptoms of depression. These are functional somatic symptoms presenting in major depressive disorder. We went on ahead with under the aegis of the Indian Psychiatric Society, we planned another study which was a multi-centric study, nationwide study, and we studied the same in the depressive subjects. And what did we find? This study was done in 16 centers, nearly 750 subjects, drawn from tertiary care centers, medical colleges, both private and government run, and even one-room psychiatry practice. And what do we find? That the more commonly reported FSS were lack of energy, severe headache, pain in legs. They were aware of the pounding of heart, feeling tired when not working, head feeling heavy, aches and pains all over the body, head feeling hot or burning, pain or tension in neck and shoulders. My friends, it is not my intention to induce the symptoms in any one of you here. but this is exactly what the patients report about it. Well, in the context of the DAS syndrome, which is again a cultural bound syndrome, but presents primarily with functional somatic symptoms, and there the belief is that the loss of semen leads to a general debility of the body. Now there, what we find is on nearly more than about nearly 800 subjects. Again, this study has been done as a nationwide multicentric study. And what we find is again, a host of symptoms which you can see in very large percentage of patients. Really startling. Now, it's okay. The symptoms are there. We can't do much about it, so I don't bother so much about these symptoms. That's a question which you may ask, or anybody would ask that question. But the problem is that when we look at the healthcare users, we can broadly divide people into two categories: high healthcare users and low healthcare users. And what do we find is that whenever a patient presents with the medically unexplained symptoms or the functional somatic symptoms, there is a more use of the healthcare system. And not only that, this is a systematic review, a very good review actually. The same group of workers went on to find that not only it is associated with more use of the healthcare system, but it is also associated with the increased healthcare costs, increased rates of outpatient visits, hospitalizations, and overall cost of treatment. Now, that makes it, quite a burden on the healthcare services. High rates of doctor shopping, high rates of emergency visits, and then non-compliance with scheduled appointments. They are the patients who will often miss the scheduled appointments in your busy OPD. Now, what are the consequences of these functional somatic symptoms for a patient? Well, the consequences are that there's significant distress, there's a functional impairment in both personal, social, and occupational domains of the person, poor level of physical and social functioning, higher rate of disability, lower level of life satisfaction, so on and so forth, as you can see, and also remaining socially isolated, unemployed, more use of sick leaves and restricted activities, but generally they are not taken seriously by their physicians. That is something which is also found. It's important for us to understand how the patients, what do they think about the cause of their functional somatic symptoms? Well, you can see here that many of them regard a variable numbers that it's an organic disease. It's a medical illness. Let it be treated like that. But quite a large percent also think that no, our disease is because of the psychogenic factors, the psychosocial factors. Nobody is inquiring about it, but they do attribute it to the psychosocial factors. And of course, some have the neutral explanations, neither here nor there anyway. Now, some studies have tried to see what is the patient's attribution of the physical somatic symptoms, and that's a very surprising finding. Half of them think it is the physical overloading and exhaustion from day-to-day work, daily hastiness and time pressure. Some, of course, feel about 40% is a somatic disease, but even the equal number does attribute it to the weather influences also. The too hot of weather, too cold a weather, changing weather, and this is our experience also. भाई आजकल एसी मत लगाना, मौसम बदल रहा है, शरीर में दर्दें होंगी, ये होगा, वो होगा, शरीर टूटेगा. Whether it really does or not, I really don't know. But we believe in all this. Well, we planned another study, and we thought let us also study the explanatory models of somatoform disorders in patients who are attending a psychiatric outpatient clinic. And what do we find, my friends, here is that, again, going by the same trends, health, illness, injury, medical, less than 1/5. Whereas social and psychological causes, nearly 2/3, half to 2/3. Now that's amazing. So what are we treating them with, actually? Their needs are different. And karma, deed, hereditary, 1/3. Environmental pollution, sanitation problems around them, nearly 10%. And no explanation, of course, by about 1/5, about 1/6 of the sample, they had no clue as to what could be the cause of their problem. Now, my very dear friend, who is now retired as a dean from the NIMHANS, Santosh Chaturvedi, along with Dr. Desai, they did a very good study. And they tried to think about what could be they reflected on the psychosocial distress and cultural conflicts, particularly in non-sophisticated traditional societies. And they tried to make some sense of the functional somatic symptoms. And intuitively, they have made a good sense. It could be adaptive responses in circumstances where other modes of expression, like complaining, crying, anxiety, is not appreciated. So what they are left with then, to communicate the distress because of the overwork at home, conflict with in-laws, what they are left with are conflict with the employer. It is the somatic symptoms, the functional somatic symptoms. Or it could be the popular hidden illnesses, and I don't know how many of you, which are not in the recognized professional nosology, how many of you have even heard of Dharan? A very common presenting problem in the hills, very nearby in Himachal Pradesh and Uttarakhand. And what do the ladies do? They have a myriad set of symptoms, and what is the remedy for it? A massage of the belly by some trained the village woman, and that helps them. Right. Or it could be folk illnesses, which are actually a set of several symptoms which cohere in a given community, like Dhat syndrome. So you can see that there are different ways in which the patients can use their functional somatic symptoms to express their distress or their beliefs. There are iatrogenic factors contributing to functional somatic symptoms, and that's rather a matter of concern for us. Defensive medicine as practiced today, there is a pressure that we should not be missing anything, so let's over-investigate the patient. Do whatever you have to do, run all the investigative protocols so that tomorrow you cannot be blamed. So they are subjected to unnecessary investigations which reinforce their belief systems. Then, physicians pursuing organic explanations and medical investigations excessively, and that further reinforces the worry and influences the behavior of the patient. They keep on bringing their whole dockets of the consultations and investigations, and doctors have no time to go through it actually. So they give a cursory look and say, oh yes, I have understood, you know what you are, so go to Dr. Avasthi. Catastrophizing medical advice or giving a stigmatizing diagnosis. Oh, well, you have medically unexplained symptoms, so what is there to do about it? Well, I'm writing something, you take it, it will get well. So that's the way we dispose of these patients. All this has been contributed to my mind. I'm very unhappy the way the medical system and the medical care has been fragmented. Resultantly, it goes to a particular specialist, and somebody will look at his legs, somebody will look at his heart, somebody will look at his, the head, or somebody will look at his, just the stomach, and beyond that nothing, no holistic view of the patient's complaints. So if you have a biopsychosocial model, where is a holistic way of understanding the patient's complaints and their presentation, well, that would be the best way to deal with these patients. All of us know it. I can tell you, forget about non-psychiatrists. Forget about psychiatrists. Even the non-psychiatrists know it. That there are bodily perceptions. Patients have their own knowledge and beliefs. They have their own personalities and mental states. And that leads to cognitive interpretations of their normal physiological sensations. And there are maintaining factors like physiological, psychological, behavioral changes. There's the influence of iatrogenic factors, how others react to their symptoms, and therefore the symptoms, behavioral change, and disability we understand. But it is not put to practice at all. We know it theoretically. We all have a sensitivity toward all this. But actually it is lacking in our practice. I'll give you an example of a chronic pain. Now look at it. If there is somebody presenting chronic pain, you will say there are some people who are predisposed to varying sensations of the perception of pain. Some people experience pain more, some people don't experience that much. There is also the injury, if at all at work, it serves a precipitating factor, and then the effect of immobility will perpetuate the disability and distress and the pain also. Psychologically, if there is a lack of care as a child, you are neglected, and whenever a trauma takes place, there will be a dependency reaction. So either you will have a more dependency on your caretakers and caregivers and fear of worsening pain, or there will be an avoidance behavior, so you will be avoiding the activity or taking any responsibility for the normalization. In interpersonal, there could be a family history of illnesses, so you are tuned to the physical symptoms, dissatisfaction with work, response of the employers are at home, and then there could be either an over-solicitous care or a litigation process. All these things are very good. We all know the importance of these. But what happens in real-time practice? In medical system, somebody presents with headache, focuses solely on headache, you keep giving the NSAIDs, the opioids, the triptans and whatever you have under your armamentarium, and hope that the headache will go away. The patient keeps bouncing back like a ping pong ball. He keeps bouncing back. And then you wonder what to do. And it makes you feel so frustrated actually. Now, Ronneberg and his associates did review a lot of work in this area, and they looked at the hypothesized theories or explanations for the functional somatic symptoms. Now, there could be the amplification of sensory stimuli. Maybe that people get sensitized to the functional somatic symptoms because of the repeated occurrence of physical symptoms, genuine physical symptoms in their lifetimes. There is a sensitivity theory depending upon their personality, like negative affects or neuroticism, and they get very sensitive to develop the functional somatic symptoms. There could be a dysfunctional sensory filter, so they cannot differentiate between the physiological processes and the pathophysiological processes. So they have a difficulty. There could be autonomic nervous system dysfunctional theory, which takes into account the role of the parasympathetic system. There could be illness behavior theory, and they feel that the patient has assumed a sickness role and he's just thinking, clinging on to the being a sick person for whatever the reasons. And then there could be immune system sensitization theory, which thinks of the perpetuating outflow of the brain cytokines and pro-inflammatory factors. There could be endocrine dysregulation theory, which takes into account the HPA axis dysfunction and hypercortisolemia. There is abnormal proprioception theory that some people are very sensitive to the joint sense positions, and they feel a lot of problems with their joints. Illness belief theory, we all understand what it is. And then there is a meta model of cognitive behavioral theory, which takes into account the predisposing factors, the precipitating factors, and the perpetuating factors. And lastly, of course, the biology first hypothesis. Now, the same group they refer to a general model of explanation for these symptoms, which takes into account all these hypothesized theories, and then they have certain triggering factors, some maintaining or aggravating factors, and then you have chronic disabling bodily distress. So all these factors will need to be accounted for. Poor communication to patients, dismissing the patient or the symptoms of the patient, and psychiatric referrals without explanation are the commonest barriers to the management of the functional somatic symptoms. I think at the clinician level, we must make attempts to improve the communication skills of the clinicians. This is something which is lacking even today in our medical curriculum. And there is an empathetic listening of the patients, an ability to empathize with the patients, and allow the patient to narrate whatever he wishes to. Don't dismiss him or her. Avoid being in haste, because they generally feel that nobody listens to them. They are very happy if you have listened to them. Half of them are very satisfied only by this only. At least somebody listened to them. Do not interrupt the patient while speaking. Understanding the patient's own understanding of what is the cause of their symptoms, and ask about the personal concerns. If you have to assess at each visit, at least some physical examination must be performed. It is their expectation. If nothing else, just look for tremors in the extended hands or feel the pulse. Just do that, or make them walk, Just, but at least some physical examination should be part and parcel of you. Review the treatment records very seriously and give due attention to it. Avoid premature proposals of the interpretations or referrals, and you must know what investigations are to be ordered, and more importantly, what does negative or positive results of the investigations mean to you and have to be conveyed to the patient. Because patients are very scared, and when and how to refer the patient, they should not feel that they have been kicked out of your clinic in some guise or the other, and they should not feel abandoned. That's something which you ought to do. A very ingenious study was done by my friends in the department, along with the rheumatology department. You can see the name of Professor Aman Sharma there. And this was a very interesting study where they had two sets of symptoms. One, which was attending the psychiatric services, and the two who were unwilling to attend the psychiatric services, and they tried to see what is the difference between the two of them. And what they found was that compared to patients attending the psychiatry outpatient services, those who were attending the rheumatology outpatient services alone and unwilling to go to psychiatry, they had higher levels of somatosensory amplification, more of health anxiety and morbid beliefs about their health. They had difficulty in identifying and describing their affective feelings, hence they had to somatize, higher stigmatizing attitude towards the mental illness, and poor quality of life and higher disability. Therefore, patients do well when they come to the psychiatric clinics, or at least if there is a collaborative care between the primary physician or surgeon and the psychiatrist. The general principles of initial assessment, the first time assessment, is identify patient's concerns and beliefs, review the history of functional symptoms. How much is dysfunction? That's very important to know, because your effort later on is to normalize the patient despite the presence or absence of the functional somatic symptoms. That's your effort. Explicitly consider both a genuine disease or a functional diagnosis. Both could be present also. It is not either or situation. Then, appropriate medical assessment, ask questions about patient's reaction to and how they are coping with those symptoms. You may use screening questions for the psychiatric and social problems, and one must interview the relatives. Give some time to relatives. At times they will part with some informations which will be so crucial to the management of the patient. Well, friends, subsequently, you must establish a diagnosis and rule out differential diagnosis. You must come to some understanding whether this is indeed a functional somatic symptom or not. Right? Then assess for symptoms and risk factors. Specific management treatment strategies must be charted out along with not only in your head, but in a therapeutic alliance with the patient. Engage the patient in therapy. It is not one-time consultation that will help. They must keep coming to you time and again. Only then they benefit. And of course, you must have some idea about the personality and concern about physical illness in the patient. Use appropriate physical examinations, investigations. Identify depression, anxiety, as already said. Regular scheduled appointments. It is not that as and when they want to walk in. No. Give them regular scheduled appointments and perform a brief physical examination, as I told you, at each visit. For psychiatrists, don't think functional somatic symptom is a functional somatic symptom always, or this is definitely a functional somatic. It could be a limitation of your knowledge of medicine. So for any psychiatrist, if he has to be a good psychiatrist, he has to be a reasonable physician. And for any physician, even if he's an excellent physician, he has to be a reasonable psychiatrist also. So we have to have a respect for the both physical and mental aspects of the total health. Now, anemia, diabetes mellitus, hypothyroidism, vitamin D deficiency, the patients are presenting you with these problems. And they could have these symptoms associated with these diseases. And you will call it functional somatic symptoms. That will be a very, very unfortunate situation. Or there could be even some not so common diseases like Addison's disease, hypercalcemia, hyperthyroidism, secondary hyperparathyroidism, HIV, celiac disease, SLE, hyperprolactinemia, certain carcinomas, and at times even myasthenia gravis, Wilson's, porphyria, multiple sclerosis, and so on and so forth. So you must have a reasonable knowledge of excluding these diagnoses whenever you think patient is presenting with the functional somatic symptoms. Depending on the clinical presentation, effort must be made to rule out these conditions on the basis of history and relevant investigations, and a balance must be kept between over-investigations and the under-investigations. Don't follow the protocols of investigations for this disease and that disease. That is a different game altogether in different settings, not for this kind of patients. I have all the respect for those protocols, certainly, but those are for different set of symptoms, a different set of patients. Now, general principles of management are that first of all, make the patient feel that he is presenting with a real-time problem. That you must make the patient understand that these symptoms are real and you are familiar and you have seen many patients with presenting with the same type of problems. Provide positive explanations, offer opportunity for discussion, give practical advice on coping, identify and treat depression, discuss and agree a treatment and plan, and follow up and review. Well, friends, establish therapeutic alliance. So you must express genuine empathy, reflecting and validating what the patient has said. These are the skills, soft skills, which each clinician needs to develop and be trained with. Emphasize that the patient's symptoms are real and familiar. Allow patient relators to ask questions and agree on a treatment plan accordingly. Explanations should attempt to integrate psychological and biological factors and provide patients and doctors with a model for managing the condition. Discuss the diagnosis, make a positive diagnosis, give hope, explain mind-body correlation, and guide about persistent physical symptoms. These are all very essential skills which you need to develop. Good news, there is nothing wrong with you. This is a very bad explanation actually. The results of the tests have ruled out anything bad. There is not much we can do with these symptoms. There could be psychological reasons for all this. Go somewhere else. I'm not sure your symptoms are as bad as you say. Please avoid these kind of utterances. These are very damaging for the patient. You're absolutely fine, it's going to be okay. It doesn't help the patient at all. Rather, say, do you mind if I ask a second opinion from one of my colleagues who can help me in understanding your illness or symptoms? If you want, I can make a call to him, her, maybe making an actual call, and is very reassuring. And this is what I keep doing with Professor Prabhakar, with Professor Basin, with Professor Verma, with Professor Behra, even today. So I called them, even today I called you, sir. And we discussed, and the patient was sitting in front of me. And it was so reassuring for the patient that I had discussed the whole case with Professor Prabhakar. Now, that is highly reassuring. One way to persuade patients with psychiatry, we cannot find immediate care for your symptoms, but we need to help you to find a way to decrease your distress, increase functionality. And eventually, that may even help amelioration of your symptoms. That needs to be emphasized. Don't abandon the patient, please, or don't be dismissive towards the patient. There are certain psychological interventions which are rather more sophisticated interventions. I will not go into that. Pharmacotherapy, no place at all. Very poor, low quality evidence of no use. We know what fate opipramol got received while we attempted to use it for somatoform disorders, and so on and so forth. So no use. So you may keep on using any drugs unless there is a diagnosable psychiatric disorder. Then it is fine. More than half of patients with functional somatic symptoms will definitely improve, irrespective of the setting to which they are in. So don't be fatalistic about the patients. Just keep them with you. Outcome influenced by the number of functional somatic symptoms at the baseline assessment. And life expectancy is presumably normal. They don't die of these symptoms prematurely. I can assure you that. Now, why the medical profession is failing to address functional somatic symptoms? Most of the patients, obviously, with bodily symptoms will go to physicians. You can't blame them for it. But unfortunately, in our training, physicians have a very poor exposure to principles of the psychosocial interventions or even psychosocial understanding of the patient's problems. Poor orientation, improper referral, stigma attached to going to psychiatrists, all these problems. And why there is stigma attached? Look at this. He goes to a psychiatrist in the hope that something different will be done. He writes another set of about 10 medicines and gives it back, the prescription, to the patient. And patient wonders, why did I come here? Or they feel that this patient is going to take too much of time, it will just waste my time. I will earn more by seeing other kind of patients. It's easier to treat depression or anxiety than to waste your time with these kind of patients because they are highly demanding. I have a certain evolved my own approach to managing functional somatic symptoms. My friends, both in psychiatry and in other specialties, will bear this out, that I had a particular interest and I would say a preference for dabbling with patients presenting with non-psychotic illnesses. It was there in my clinics, even the residents working with me knew that Dr. Avasthi means he's very much interested in non-psychotic disorders. Non-psychotic, not non-psychiatric, non-psychotic disorders. As soon as I entered the portals of the private practice, I found it very useful for me. Because so many patients floating around, right? And they come to you, and then I had my own insights based on the knowledge which is there and the clinical experience that I had. So what I do is I listen very empathetically to the patient. I spend time, never appear to be in haste. This is also a skill. You can do your job in 7 minutes without appearing to be in haste, and you can make the patient feel as if the patient has spent 27 minutes with you. This is all based on your skill, how you talk, how you approach, it has to be practiced. No confrontation, understand the patient's etiological model. I do physical examination as a psychiatrist. I don't shy away. And scheduled investigations, I do order investigations also wherever required. And engage the patient. For keeping the patient engaged with you, if such is the case, patient has his own understanding, they often present with distress and anxieties. And even if this is a sub-threshold level, you may not be able to diagnose a depressive disorder or a definitive the anxiety disorder. You may require a modest dose of psychotropics which will keep the patient in therapeutic net. I request the patient to stick to one therapist, me or elsewhere. But don't go for multiple consultations. Stick to one therapist. Share my understanding of nature and cause of symptoms. I focus on normalization of the patient. And last but not least, I discuss with my referring colleagues, and that is very, very reassuring for the patient. Whatever the patient is comfortable with, I use that kind of, the percepts of that kind of the theoretical model for their treatment. But I have found in my practice, physical and relaxation exercises, they work miracles with them. They keep them engaged. It has a positive health effect, and they think something positive is being done about that. Once a patient with FSS is not always a patient with FSS. He can present with some other illness also, a medical illness. So I'm open to re-examination. Each time I listen to them very carefully, lest I may be missing something. Well, my friends, ubiquitous functional somatic symptoms are enigma for the patients and also the clinicians. Proper management requires a thorough assessment, developing a therapeutic alliance, specific skills of management, use of appropriate psychotherapeutic interventions, maintaining a good liaison with other medical specialists. And that's why I had more friends outside my department in PGI than what I had the number of friends in my own department. And everybody will vouch for it. So I would interact with them, I would go to them, I will try to learn with them. Professor Veklal, you can. And this is all, I had a patient recently, not recently, but sometime back brought to me, 40 years of the persistent, tenaciously held functional somatic symptoms, admitted thrice in tertiary care centers, premier tertiary care centers, even received ECT. Patient came to me, all these maneuvers, nothing more. Today, even yesterday, the patient, not yesterday, but the Saturday, the patient, day before yesterday, the patient had come and she's more interested in discussing about her problems with her sons and the who she thinks are good for nothing, and her, daughter-in-laws, rather than talking about her functional somatic symptoms. And I leave that. I don't gloat and don't tell her, didn't I say you so? That your problem is with you at your home rather than with your body. I don't make that mistake at all, because that will reverse everything immediately, So I keep my patience with that. Well, I am extremely grateful to my teachers and mentors who have made it possible for me to stand in front of all of you. I am very thankful to my colleagues in the profession who helped me to develop my critical thinking. I am extremely grateful to my students, the powerhouse of my knowledge and clinical experience. And I am very grateful to patients who have trusted me, who have cooperated with me, and most importantly, they have forgiven me most of the times, for my blunders. And of course, my family, who has tolerated me for all these years, very resilient family, I must say. Well, my friends, it's out of a sense of gratitude that I present you this particular photograph. My gratitude to my Department of Psychiatry. And as I can see with a heavy heart, that 4 of my teachers are no longer with us. Professor Vig, Professor Vijay K. Verma, Professor S.K. Verma, and Professor Dwarka Prasadji. So they are not with us. We have also lost the first and I would say the only mother figure of the department in Mrs. Vig, whom Professor Vig would very fondly address as Veena ji. That's what he would say. Well, I am also very sad to see some of my seniors who are no more with us, like Dr. D.K. Menon, Dr. Vrinder Mohan, my class fellow, even from the pre-MBBS times, Dr. Rajiv Gupta. And I also see here my very dear and illustrious student, Professor Bir Singh Chavan. We have lost them. And a very helpful board aide, Mr. Kripal Singh. Well, this does not sum up the faces of the department. There are many more illustrious people who have achieved so much and done so much. There are very illustrious people standing here. If I talk about each one of them, they are institution themselves. But there are many more who are not in this frame. This is the Golden Jubilee celebration photograph. But I will particularly like to mention, I'm very sure again, that many brighter and more illustrious people will be there in subsequent photographs of the department. I'm very sure about it, and that's the strength of the department. That is what makes us what we are, the people who are PGIs from the Department of Psychiatry. And then there is a young man, lastly, whom I would like to acknowledge. He's standing by the side of my buddy in Fortis, Dr. Hardeep Singh, and he's there. He held my hand, when I made my foray into the private practice. But the gentleman I'm referring to is this young man with a check trouser, I hope so. And he's the present day Professor Sandeep Grover, the man with whom I have worked most in my professional career in the last 25 years. And on the functional somatic symptoms alone, we have worked very hard together and have published more than a dozen of very high quality research publications which got accepted in journals with very high impact factors. So now, my friends, I think this is about time for me to finish. I hope, my dear teacher, you are somewhat satisfied with this presentation, and thank you very much for your
Thank you, sir. Thank you for such an insightful and mesmerizing talk. And I'm sure that each one of us present here must have learned something on how to manage functional somatic symptom. And if we practice it, then we can make lives of patients with presenting with such symptoms to be very great. So with this, I would like to request our Director Sir and HOD Dr. Basu Sir to present memento to our speaker, Dr. Avasthi Sir. I'd like to thank my heartfelt gratitude to the chief guest, the speaker of today's event, our honorary director sir, for chairing this session, Mr. Siddharth Wik, who has come all along for this oration, our past former directors and deans and current senior professors and past senior professors from different specialities who have come to grace this occasion. I also like to